Can you hear me now? Perfect. Okay. Good evening, and thank you so much for joining us this evening for the second night of our 6-week series titled Celebrating Life, Understanding Death. Today's topic is understanding the dying process, and also we'll be covering the debunking myths of hospice care. Our guest speaker today is Dr. Richard Zorn. We're so grateful to have him. He's very loved and respected, longtime surgeon at TMH and professor at FSU. And when Dr. Zorn retired, he came to work at Big Hospice with me. So I'm very grateful to have had that experience. I was able to work with him on the same team where I saw him clinically is just superior in understanding what patients' needs are, but also his bedside manner was amazing, and the way that he advocated for patients and families that were having a significantly hard time, I always appreciated. So I feel very grateful to have you. Thank you so much for coming and joining us, Dr. Zorn. Tonight, we also had invited Crystal Bear from Covenant Care. Unfortunately, she had an emergency and won't be able to join us, but I think that Dr. Zorn and I will be able to handle the common hospice myths. So I would like to make sure that you all have your handouts. We have handouts here, and there'll be a link provided. And this is the handout on common hospice myths. And we also will have an evaluation. Please make sure to complete those evaluations. It really helps us in preparing for the next 4 weeks. And we'd love to hear what you enjoy about these presentations. So I'd like to go ahead and get started. Dr. Richard Zorn, if you could please come. Thank you very much for being here. You got your mic?
I'm blue.
You're blue.
Can you hear me? Well, thank you very much for having me. This is a great privilege. I guess I got an early introduction to death and dying. My father was a Methodist minister in South Georgia, and he would take 2 weeks off during the summer and go to the Army for reserves. And he would come back with crisp $100 bills, and that was what we would use for vacation. I thought we were rich for about a week. You don't make a whole lot as a Methodist minister in the 1950s. But anyway, vacation was real important because ministers work on the weekends and they work at nights, and we were in school, so the vacations were really important as far as bonding with our father. But we soon learned that he also was very dynamic in his visitation for what he called the shut-ins, the people that could not come to the church on a regular basis. So he had a regular visitation schedule, and if there was any change in their condition, then he upped his visitation rights. Or of course, if anybody died, then he was expected to do the funeral. So we would get the car packed, and there were 3 boys, and we would be sitting in the back seat. And as you know, 3 boys would be claiming their space and everything. So it was always a little bit antsy there. And we were just waiting and hoping the phone did not ring, that it was somebody whose condition had changed, or somebody who had died, or something or other that was going to call my father back, and we would be not leaving on our vacation. Now, luckily, this was during the time of landlines, so if we could get down the road even only a mile, nobody could find us. So I think this was sort of the exposure to death and dying that a lot of people take. This, just don't let it happen this week. I'll do something about it next week or the next month or whatever. So I think it's sort of an early introduction of how to avoid the topic. I would like to take a little bit of introduction on the Zorn family. There's been a lot of confusion. My brother and I have just started accepting responsibility for all the daughters and sons and grandsons. I used to have a mustache, and when I shaved my mustache off, it threw the whole community into total confusion because they could not tell us apart. So like I said, there were 3 boys. They were son of a Methodist minister and all went into medicine. Don't ask me why. I don't know that any of my older brother probably always was going to go into medicine, and the other 2 of us may have just sort of tracked along behind him. Emory was very good to us, so we came out of it not too much in debt, and we didn't hit my father too hard. So my older brother George is a retired cardiac surgeon in Birmingham. His oldest son is a cardiac surgeon in Kansas City. His daughter is a GYN oncologist in Little Rock, and his other daughter is a veterinarian in Demopolis, Alabama. My younger brother Don was the director of the family practice residency program for many years. He is now retired here in Tallahassee. His wife Tasca was a nurse at Holy Comforter for many years. So Tasca goes with Don. We're going to have a test at the end, right? Remember the old test? Remember the old test where you had a column over here and a column over here, and you had to match which one? Yeah, we're going to do that. So Tasca goes with Don. Their oldest daughter, Sarah, is interior design, living in Georgetown. Their son, Austin, is in family practice here in Tallahassee. And their daughter, Susanna, practices sports medicine, and she will be full-time with TOC starting in July. She also works with the FAMU football team. I went to Emory College and medical school and did general surgery residency program at Emory and Grady. I came to Tallahassee in 1978 and practiced general surgery until 2017. Dealt with a lot of breast cancer patients at various stages of their disease. My wife is Kathy, and she's the owner operator of Bright Star Kid Care over on Old Bainbridge Road. That's a 2-hour discussion that'll have to be done separately. I have 3 living children, daughter Leanne, who works for the Attorney General's office, daughter Kelly, who works in daycare here in Tallahassee, and my son Tyler, who is just finishing his cardiovascular fellowship at Vanderbilt and will be joining his cousin in private practice in Kansas City in July. After finishing practicing surgery, they said I worked 3.5 years at Big Bend Hospice, mainly doing inpatient care at the Dozier House. And a lot of this talk comes from that experience there. Before people get sleepy or hungry, I would like to make one strong recommendation. If you or your loved ones can avoid dying in the hospital, I would strongly recommend it. A hospital is not a place to die. It is a place to go and get treatment. If you have an acute thing and you have no choice, or the rapid deterioration and you can't manage to get out of the hospital, that's an entirely different subject. But if you have chronic illness with slow deterioration, try to do everything you possibly can for you and your loved ones not to die in the hospital. They have monthly incident reports of oversedation. They are not trained in the use of narcotics. And even if you're in the hospital with hospice oversight, the medications are being given by the hospital staff, and they're just not into the type of program that you need as end of life. So I would strongly recommend, if you have any control over your situation, that you try not to die in the hospital. The topic somewhat implies that I'm going to talk about just the very end of life. I'd like to move the calendar back a little bit and talk things that happen even before death is imminent. Death is a process. And like Forrest Gump's mother said, death is just a part of living. For some, the process can be short and for others, it can be longer with many twists and turns. That is why you will be probably encouraged many times during this series to make as many decisions as you can as soon as possible. I don't think any of us want our death to be bad, not only for our own sake, but for our loved ones. We don't want to be their last and have their last memories of us be painful to recall. It is very discouraging to listen to people describe the death of a loved one as something that tears a family apart rather than bringing them together, especially if it could have been avoided with some early inclusive decisions. So this talk will begin a little earlier with some changes that occur and might prompt these early discussions. First thing that a lot of people talk about that they notice changes in is mental acuity. This can be gradual or it can be very dramatic. There are some drugs that you'll see on the market like Prevagen and Nareva that have not been proven and could have other side effects. There are some things like word games or brain activities like crossword puzzles that might help some people. People always want to know what's the difference between normal and abnormal differences as far as memory loss. Nouns seem to be especially prominent in normal memory loss. People and places, especially if you don't see them for a long period of time, where you put something, timing and order of events. There are different kinds of tricks that you can use. Writing things down may use a different part of your brain than just listening. List, mine's about 3 things. Anything more than 3 has to have a list. Using your phone as a calendar. Some things as far as sequencing, if you're trying to remember something, you might try to remember whether it happened before or after some bigger event, such as a holiday or a family event. Abnormal types of changes would be not remembering names of family members or people or places that you see every day, not remembering where you are, how to get home, not remember the rules of driving. This might be a time to discuss taking the keys away, but that's an entire talk in and of itself. This is the time to discuss the situation with your physician. Drugs at this point in time, such as Aricept, might be helpful for a short period of time. The reason for making decisions early is so you have some control as long as you are mentally able. Try to be as specific and include all stakeholders. It is very discouraging to have an alienated member of the family show up when you're on death's door and they have entirely different ideas about how things ought to be handled than the people that have been taking care of you for the last 5 years. It does make for some interesting times. To try to bring all the stakeholders, and it's also probably easier for the person that's the subject of the discussion to bring all people's involved into the discussion. Try to be as specific as you can about the decisions. Everybody talks about intubation and feeding tubes, but you need to talk about things like medication levels, whether you want to be heavily sedated or lightly medicated, or how hard they should push nutritional support or activity levels. So again, a lot of discussion about how you want things handled before your mental acuity begins to change. Second thing is decrease in physical ability. This also can be gradual or dramatic. Different things might help. Flexibility and balance activity may slow it down some. This may be the time to consider aids like canes or walkers or wheelchairs. Also, changes in the residency as far as possibly moving the bedroom down to the first floor, using ramps instead of steps, or possibly even a complete change of residency. Some overlap with this is falls. But again, I think it's important because falls can change dramatically A person who's completely independent can be completely dependent after a fall, especially if there's a fracture associated with it. The 1-year mortality for elderly patients with hip fractures can be as high as 50%. So safety checks on your residency as far as loose rugs or all objects that might cause you to lose your balance. Again, decision on steps or ramps, changing the residency outlook. Some studies have shown that the rate of falls is not related totally to more incidents, but might be related to your lack of ability to recover once you have an incident. So working on balance and flexibility might be something to think about. Also, doing things a little bit differently. If you've always been carrying 2 bags of groceries in at a time, maybe just carry 1 bag of groceries in and keep one arm as a safety mechanism to grab hold of something as you fall. Most of us have plenty of time, so 1 bag of groceries at a time ain't gonna push us that much. Next thing is deterioration in medical conditions. I think the new system where the primary care physician does not go to the hospital has caused some problems with this, because even if you go over in fairly great detail with your primary care doctor about what you want done or not done, when you get acutely short of breath or have an episode of chest pain, most likely you're going to go to the emergency room and you're going to see a doctor you've never seen before, and you're going to get admitted and see a hospitalist that you've never met before. And just about the time they're figuring out who you are, they're going to change to a different hospitalist. So you kind of need to have a lot in your mind about where you want these trips to the hospital to go, because as things progress, there are going to be more hospitalizations, more doctor visits, more medication changes, and what you need to evaluate is what you get as bang for your buck with each admission. Because hospital admissions are invasive. Most of the treatment has to be done IV. As you do it more and more, it's going to be harder and harder to get an IV, and you're going to possibly have to have a PICC line put in. Your medications are going to be changed. And the main thing that happens to a lot of people is they spend time in bed and they get incredibly weak. It's amazing how quickly somebody who's functioning reasonably well goes to the hospital for a few days. They don't get out of bed and don't do anything, and then they go home and they can barely get out of bed at all. So the decisions about whether to go to the hospital if you have an acute deterioration in symptoms needs to be done when you've got everybody in, rather than when you have the acute event. Other is loss of appetite. This is a natural course of events in almost all disease processes. And again, you need to discuss how hard you want to be pushed as far as this. It gets to be a real issue and can cause a lot of consternation for the caretakers when the person they're caring for decides they're not going to eat anymore, or they're just going to hold it in their mouth. They're not going to take medications. It's a good time to go over medications, because treatment of chronic illnesses at this point in time probably is not something that you need to fight with somebody over taking medications for their cholesterol level if their life expectancy is now less than a year. Different things you can try as far as supplements like milkshakes. I had a patient that I took out all but 14 inches of his colon when he weighed 300 pounds, and he lived almost totally on milkshakes for the next 8 weeks and lost down to about 220 pounds, but I saw him about a year later and he was back up to 260 pounds, mainly on milkshakes. Consistency also can be changed. A lot of people do better with thickened liquids instead of thin liquids. Some of it may be swallowing difficulty related to different medical conditions. and you may have trouble overcoming this. There are some studies that showed for, especially with dementia patients, that placement of G tubes didn't, for people who had stopped eating, did not change the mortality rate. And again, early discussions about, how aggressive you want to be with this, because again, it gives a lot of consternation to the caretaker to have somebody not eating and losing weight. The other is change in sleep patterns. You go from normal sleep patterns to sleeping almost all the time, or insomnia, especially at night. It's very helpful to try to keep a normal diurnal pattern, especially for the caretakers. It's very difficult to care for somebody if you're not getting your regular sleep. So trying to keep them, or keeping yourself on a regular pattern, is very helpful. A lot of times it's very difficult to do, though. Trying to do some type of activity during the day that might tire you out, or create some better opportunity rather than sleeping during the day and staying awake and driving your caretaker crazy at night. There are medications that help, but you have to be really careful with them. There seems to be no real good middle ground. It seems to either not work or end up with over sedation. So you have to be really careful with sleep medications. Another thing is pain. A lot of people end up with pain toward the end of life. This can be related to ongoing medical conditions, or just debility, or other issues that come up. You hopefully will be able to keep it under control so that it does not accelerate the other deterioration in other areas. There are non-medical types of treatments, such as music or heat, cold massages, who in this kind of situation, you do whatever works. There are some narcotic patches that also seem to be help. Have to be extremely careful with narcotics at an early age or early stage, because constipation is a real bad side effect with that. You also have to be careful with NSAIDs like ibuprofen, naproxen, and Celebrex, and high-dose aspirin for GI and other bleeding episodes. Next thing is bowel and bladder problems. This can go anywhere from retention to constipation to incontinence, infections, or requiring more and more assistance. The main issue seems to be most of the time is constipation. This sometimes can be handled with increased water consumption, or fiber ingestion might help. But a lot of times more outside help will be necessary. What you try to do is try to keep from embarrassing the patient, and keep some modesty in the activities so that they can be dealt with in humane ways. Other changes: need for increased assistance with activities of daily living. This may require a full-time caretaker. Again, early planning and discussion. Changes in clothes, to use more all-purpose clothes with Velcro or elastic or things might be helpful. You'll find that you don't need to change clothes as many times if it takes 4 people to do it. Other is behavior changes. A normal, calm person sometimes can become very aggressive with cussing. Seems to be sometimes related to loss of inhibition controls. Different parts of the brain are affected differently with aging. So somebody who's never uttered a cuss word in a public life before may turn into the worst cusser that you've ever seen. But again, just remember that it's part of the process, and needs to be just dealt with. It's not related to something they're doing to get attention or whatever. Sometimes there's sexual acting out. Just understand that emotion is a very elaborate control system. If you realize how upset you can be at certain times and just have your grandkid walk in and smile at you, all of a sudden everything's all right. So in conclusion, in decision-making, consider whether it is affecting quality of life. I think that's the most important thing, both for yourself and whoever you're taking care of. Is this going to make their quality of life better? Is it going to not make a big deal of it? Remember, you're not going to cure anything, but trying to make the process as smooth as possible for all concerned. Thank you. You want to do questions now or later, or what do you want to do?
Yeah, we have at least one question.
I do have one question,
Okay,
and I'll just read that out to you, and then you can respond.
okay.
How do you calm and sedate someone in hospice with chronic neurological disturbances like swirling or sway?
Most of the time, it's going to take medication. There are different kinds of medications for control of it. It's a very difficult problem because a lot of times the magic point is either you don't have enough medication, or the medication doesn't work, or the medication over sedates them. So it's a very difficult problem to handle, but most of the time it's going to take medication. Okay.
Dr. Zorn, would you like to maybe share at what point a person is appropriate for hospice, and maybe how that process of the decline and then the care?
Well, everybody used to think of hospice as being something that you didn't consider until you thought you were at a 6-month time of death. But now I think it's more an evaluation that's based on where that patient is. So there's not a finite 6-month length of life associated with it. I think what you need to understand is that taking care of somebody is just as hard on the caretaker as it is on the patient. And bringing hospice in, at least for an evaluation, does not mean that you're giving up, on treatment of the patients. In fact, a lot of the patients, when they're enrolled in hospice, are being seen more often by more people than they would be if they were under the care of a private physician. So it's not unusual for a hospice patient to have sort of a rebound in the first part of it based on the amount of attention they're getting. And Medicare has gotten easier on recertifications too. There are not very many people that are getting kicked out of hospice after a certain period of time. They have to be reevaluated by a physician, but Medicare is not pushing hospices at this point in time to kick patients out. The one area that's very difficult to deal with is dementia. And that's you're just going to have to get somebody to come in and do an evaluation. But if there's been a rapid deterioration, weight loss, and increased need for care with activities of daily living, I would encourage you to get hospice involved early. They may not take them, but they might get them in a transitions program or something else where they would be continued to follow, because most of the studies show that the patients are late getting in hospice, not getting in too early. The feeling that you're giving up hope or you're not going to do anything to care for the patient if they go in hospice is sometimes, kind of hard to get through. People don't want you to identify as hospice or come in an unmarked car or whatever because of family concerns. But And what I think people are pushing toward now is not necessarily even having the family completely on board with all the decisions that we're talking about to make that part of the learning process once you get in hospice. That does make it a little bit difficult on the hospice physician sometimes knowing, exactly whether this patient needs to go back to the hospital or whether that's, improving their quality of life with them to get treatment in the hospital for several days for some undergoing lung process, or whether they would be better just having their medication changed at home. But again, I would encourage you to get an evaluation early rather than later.
There's one more Zoom question. Will Medicare pay for hospice if the patient is outside the 6-month window?
If they're recertified, they have to be recertified. They have to be seen by a doctor and recertified. But again, Medicare has gotten, not very many people get kicked out of hospice just for longevity. They have to have shown signs of improvement or other things that they don't meet criteria.
And are you staying there 24/7? And if so, how many rooms do you have?
At the Dozier House, there are 12 rooms and they stay there 24 hours. Now, once this is what's called inpatient care, there are certain criteria that you have to meet for inpatient care. But so not everybody qualifies for that. The majority of hospice patients are taken care of at home or in a facility. But again, I would encourage you to make plans, not to spend your final days because of visitation restrictions and other kinds of different things. It's just not meant for a type of death that most of us, I think, want. That is just very difficult to manage in the hospital. Yes.
Does Dr. Zorn have notes he can share with us?
Are there resources? Are there like online resources that might?
Not that I can specifically point to. Maybe Betty and I can come up with something. These notes won't get you. I can't even. Part of doctor's training. Good thing nobody has got it on legibility.
Any other questions? Are there any other questions here? Any other questions in the room?
One more Zoom question.
Okay.
Somebody has asked about any book recommendations.
Dr. Ira Byock. That would be good.
Yeah.
Dr. Ira Byock. I know, I can't remember. It's like the 5 things.
Tell them what.
4 things that matter the most?
Yes. That is an excellent note. You want to stay up there and join me?
You want me to leave this on?
Yes, we do. Okay, I'm gonna join Dr. Zorn now, and thank you so much, Dr. Zorn. I so appreciate that you started with, by far, most of us, if we were to take a poll online or here, most of us would imagine and want to be at home, in our own home, surrounded by the people we love and our pets and in our bed. And so hospice care is very important care. And even though it's a non-curative care, it's a comfort care. It's about quality of life. And they're able to provide that kind of care, like he mentioned, where they would come in more often, make sure somebody's overseeing the medications, make sure they're eating, make sure the caregiver is getting support. So hospice care is about providing support to the patient, but also the caregiver. So together, we're gonna go over some of the common myths that was provided for you. That's in a link and part of your handouts, and this was provided from Covenant Care. And then we'll have a wonderful video to share that they had submitted for us too. So I like the very beginning is saying hospice is often misunderstood. And that has been the case. I remember when I was a teenager and my friend said her grandfather had been admitted to hospice, and I thought, I didn't know what she meant. I thought that meant he was going to the hospital and that he was out of place. But just like Dr. Zorn said, by far, the majority of hospice patients are in their home. The Hospice House for Dream and Hospice has 12 inpatient, but probably a census of 360 patients. And since people want to be at home, that's how they provide the care. They go into their homes, there's a nurse and a social worker and a chaplain and home health aides, music therapy. So all of those are provided according to what the family wants. They are assessed, there's a plan of care, they make those decisions, and as their needs change, those are addressed. So, but sometimes the best way of explaining hospice care is clarifying these myths. So the very first thing is that hospice is a place. Like we said, it's not, it's a service. So they will go to wherever, by far, most are at home, but if the patient lives in an assisted living facility or in a nursing home, if the patient is homeless and is living in their van and that's where they want to be cared for, the hospice team will go there. So understand that care is provided wherever the patient wants, and whoever the family is identified by that patient. They're the ones that are going to be providing the majority of the care. Lots of hospice is overseeing and educating and preparing. So staying a step ahead so that they're cared for and avoiding a crisis and getting the best quality of life possible is what they're about.
Yeah, because when a patient enters hospice, there's a complete evaluation of their previous medical record, their medications, what activities, are there psychosocial issues or different things. So there's a complete evaluation done of the patient when they are admitted to hospice. And then these various team members kind of know what the problems are and issues are. So each, part of the team can deal with something that's in their category. And like I said, it's not unusual in the first, few weeks that if somebody's reasonably stable, for them not to get a little bit better just because of the attention they're getting. And some things, get reevaluated, their medications get reevaluated, like some of those might get changed. So it's sort of almost like a new beginning. It does sort of change, what you're doing is changing your priority level, because the issue becomes whether something is being done as a treatment, because what you're doing is you're switching from a treatment protocol to more of a symptom management protocol.
Okay, the second myth is patients will die immediately when hospice care begins.
Well, the medications that a patient is given in hospice do not either, some people come into hospice and they want death to come immediately. I mean, there's a story going around a big hospice that the guy came in and he wanted the yellow pill and nobody knew what the yellow pill was, but the yellow pill was the pill he could take and he could die. I mean, he had come to hospice and he felt that hospice would give him some kind of, and he was extremely disappointed to the point of being upset, because some people are, miserable. They're in pain or whatever, and they are ready to go. They've said their goodbyes. But hospice, in the legal state of things now, even hospice in Oregon, which probably has the most aggressive, it still has to be self-medicated. You cannot give anybody in the United States a lethal dose of morphine or a lethal dose of potassium chloride or anything else. So the medications that a patient gets in hospice are for symptom management. They're not going to speed up death and they're not going to slow down death.
I'd also like to say, I think there's often people wait to come to hospice. And so it is their final days. And certainly there's a plan of care for that. They can step in and make sure, try to get them as comfortable as possible, support the family at that time. But that isn't where hospice does their best work. If you can imagine having the time, that's a gift that hospice gives you, the time to be able to do the other things you wanted to do. If you have a wish list, if you want to have your affairs in order, if you need to mend some relationships, those are very important things. You need to forgive people, you need to be forgiven. And so that's where each member of the team, like he says, can provide better support to the whole family as a process. So to some people, hospice may never be the answer. To some people, it may be just the very end, and they certainly have a plan for that. But I feel like the best care is earlier on, where they can talk about what is it that you want, and help them do that. So, okay, next one. Patients will die immediately when hospice care begins. So you kind of addressed that with the last one. It is not that patients would die immediately. In fact, our goal, or their goal again, is to make sure, address the situation where we are now, and help that family walk through this time. Let's see, the next one is hospice patients have to give up their own doctor.
I mean, this is usually a choice given to their local, your physician, to see whether he wants to continue to manage that. Now, even if he or she decides that he will continue to manage your care, after hours, a lot of times it's hard to get in contact with that, or you get an on-call physician that, is not usually in the habit of approving narcotics at night or things like that. So even if you have a non-hospice physician, there's a hospice physician on backup call. So if you need an acute medication change, or you have a prescription or something, so you actually have two doctors if you decide to do that. Now, some physicians just don't want to manage hospice patients, so they may elect not to keep you as a patient, but you have the choice of at least us calling them and asking them if they want to continue with your care. But at night, you have backup for that too.
Okay, next question is hospice is only for cancer patients. That is an absolute false, although there is a large percentage of patients have some form of cancer, but any patient that is determined by two physicians that they have about a year left in their process, that they're transitioning into end of life, and two physicians have signed off that they're appropriate, would make them appropriate for hospice care.
Yeah, and vice versa. Cancer is not an automatic entry because there are early stage cancers. So just because you have a cancer does not necessarily, or a loved one of yours has cancer, does not necessarily mean that they're going to qualify for hospice if it's an early stage cancer.
Next myth is hospice is too expensive for most families. So I think we touched a little bit on this on the hospice Medicare benefit. So when people need Medicare, hospice follows Medicare regulations, and hospice has this Medicare benefit that you will use while you're in hospice care that takes care of all the expenses of medications, equipment, visits, physicians, nurse visits, and anything related to the terminal diagnosis. So there is no expense for hospice. If they also have private insurance contracts. If people do not have insurance, sometimes they have a sliding scale. And if people have nothing, then that's why they have fundraisers and things, but nobody is turned away from hospice if they require it, and shouldn't be any expense.
Yeah, and it will also sometimes include things that you might not consider as far as hospice care. I mean, sometimes we do very short-term radiation treatment for cancer patients for pain control, or you might do a thoracentesis for somebody who's short of breath. So there are actual procedures that can be covered, under hospice under certain circumstances.
Yeah, and I've heard some things like, they wouldn't be on antibiotics, like simple things like that, that wouldn't be covered, but hospice patients are on antibiotics all the time for pneumonia, UTIs, things.
Yeah, well,
Yeah.
it takes different, for symptom control, you're gonna need different kinds of medications. So.
Okay, and this is the last of the miss on the covenant care form, which is all hospice organizations are the same. So all hospices will have to follow Medicare regulations, federal regulations, but the way that I guess how they're accept those regulations are different. So all hospices are required to provide bereavement services or spiritual care. And so they may look different from different hospices. What I have done, and because when you work for hospice, people will ask you, what do you know, what hospice in whatever area, if they're not in this area, and especially in Florida. What I have done is always go to the website for our state association, which is the Florida Hospices and Palliative Care Association, and I go to, it's floridahospices.org. And every hospice in the state is listed there. You can see what services they have, how they differ from others in that same area. And that's usually what has helped me in being able to choose the hospice that I felt would fit our needs. But all hospices look a little different from each other.
Well, I guess the main, although I think Covenant is looking to open an inpatient facility over at Florida Hospital sometime in either they're gonna do it or whatever. I think it may have gotten affected by Covenant. I mean, about COVID, but I think at some point in time, Covenant will have an inpatient facility. That is the main difference right now, is that Big Bend Hospice has Dozier House with inpatient facility, and the Covenant does not, but looking toward doing that.
Are you talking about Florida State Hospital?
No, the hospital has changed its name again.
Non-criminal.
Yeah, it's not
The
that.
other TOS.
Yeah, well, TOH or whatever.
I did not.
No, but it's not Tallahassee Community Hospital anymore. It's some,
No, HCA Health.
it's HCA Florida Hospital, Florida Capital Hospital or something.
Sorry, HCA.
Yes, yes,
That's what it was.
that's what it was. I cannot tell you the new name.
Exactly,
It's in the same place. though.
right, exactly.
Do we have any questions?
Yes.
I'm curious about the difference between hospices that are for profit and hospices that are not. I mean, if Medicare is paying, how is anybody getting any more money out of it?
I can't really tell you how the charges work or whatever. I mean, the organization still has to be financially solvent. I mean, you can't spend more money than you bring in, either through Medicare or different kinds of things. How you get extra money for stockholders or whatever out of that, I don't have a good answer for you.
I am not sure, but I think that the only for-profit in the state is Vitas. Right? I think so, and that's in South Florida, and they're big, like national.
But there are not-for-profits. I think Covenant is a not-for-profit or whatever, but you can have a 3% margin, I think, even with a not-for-profit. So, because Tallahassee Memorial is a not-for-profit, but and they usually are in most of the time are in the black.
Are there any Zoom questions? No Zoom questions? I thought for sure we have some.
I don't have a
We do.
question.
Oh,
I don't have a question, but I do have a compliment.
oh,
I was a caregiver for over 5 years. I've been dealing with people in the medical field all of that time. When I got hospice for that 1 week, it provided so much relief for me that I never imagined. My wife asked me, why didn't we know about this? I said, I wanted this, but I didn't know how to get it.
Mhm.
Hospice told me, don't call emergency anymore. Don't call emergency anymore. I've been calling emergency, wipe them off your list. What a relief that was for me.
Yes.
She's a performer, she does art, and they provided a musical therapist for her. And for me, that was the most relieving experience I've ever had. She sang more beautifully for me, an operatic tone. She says, what do you sing? What music do you sing? She said, I sang Broadway, I sang opera, I sang, but what do you play? I play any of those. And she sang an operatic note for me. It hit the highest note serenading to me on the hospice. I was so pleased to know that I have that for just that 1 week. And then it got to a point where it was that late period in that 1 week, we need to bring you in the hospice. There's no more we can do for you here. All of her medication was for her home in the refrigerator. We could call hospice at any time and they will come and provide that. That was a relief for me. And when she went to hospice, they didn't have a bed, but they said, they'd make some beds there for her. I went to hospice and I said, I'm gonna stay here. They said, your days staying here now are over. We have nurses, doctors, 24 hours. Go home, get some sleep with you. That was the most restful period I've ever had. And then 2 days after that, I got a note, but I knew what was happening. And she left me with a wonderful feeling that she left on the hospice. She said, I want palliative care. That's what she got. And I want to thank you for that assistance.
How do you think we can get the word out to have people know who to call? Do you have any ideas of how we can do a better
I
job?
didn't even know until I was at a point where I had been going to emergency rooms and all. I had no idea. And my wife was asking me, this is what we really needed. And we didn't know how to get it. And she said, we got it on the hospital. She always conversed with me that if I go, I want to go into palliative care, but they were giving her so much medication. We went to the emergency room and they looked for codone and all of the medication I gave her. And she was over 80-some years old, and the medicine they gave her, a 35-year-old would have problems with that. Too much medication. Hospice wouldn't do that. They would make it much easier for you. And I didn't know where to go, and I had to sit under that for such a long time. And I didn't know how much I had put into this until after 4 months. And then my body had been telling me, do you remember me telling you to take care of this, take care of that? I had no sense of my own feeling, but my body went down. Oof.
Yeah.
And I went back in the emergency room in the hospital. I stayed for 8 days to get diagnosed. And people say, when you go to the hospital, that's really bad, but those are the best days of my life. They indicated me, and I didn't know men like to be pampered a bit. But I had people telling me things that they wanted to do for me. And I was so happy. I felt so much better after that. And I want to thank hospice for their service and for their care. And I do think you do a wonderful job.
Thank you so much for sharing that. Thank you.
I found several instances where it seems like the people want to die alone. They'll send their family to the nurse's station and you come back and it seems to happen. Have you found that too?
People having an idea about when either they personally are going to die or when a loved one is going to die, not very scientific. I mean, they can go to the nurse's station, but there's probably at least a 90% chance when they go back, she's still going to be alive. So it's just, I've heard theories about they're waiting on a birthday, or they're waiting on somebody to say goodbye, or they're waiting on something or other. I don't have any kind of real feeling about when it's there. My wife has a thing, when the tree falls on somebody's car and they're going down the road, well, it must have been their time. Now, that's about as close as I can get to when people are gonna die.
But not that they want to be alone.
Not, yeah.
We have had stories where people just didn't want that family member to be there when they were passing, and so they didn't want to remember that, and they have. And I think it's probably comforting to think that that was what they wanted, because sometimes it's very hard on the carer to be like, I've been here for 4 days and I left, and that's when they left. And seems kind of amazing that that window happened, and we often talk about the sense of hearing is the last to go, so there's some sense of knowing that maybe they weren't in the room anymore, and so there's lots of mysteries in life. I think.
That's one of them.
Yes,
I was just curious, what, like, that's just such a sad story this gentleman told about not knowing about hospice all this time. Does
Well, I think,
hospice do any like outreach into
Yeah.
all of, I mean,
Well, this is
my
part of it.
family did, but
well, I
this is
think,
what happened in my
well, I
house,
think-
but-
there are now palliative care services in the hospitals, and I think the doctors are more aware of people who would meet criteria for that. So I think there is more help out there that would get people to assistance earlier. But if you look at the length of stay for hospice, it's still very short. And we've been working on that for years, trying to get people into hospice earlier. So it's kind of an upstream battle, but yeah, we're trying to get people in early.
Yeah, this is a wonderful outreach
Well,
right here.
this is the librarians that requested it, so we're really grateful. And they are difficult topics, like today, everything you mentioned, those are things that scare people. The thought of seeing your loved one falling more often, or you see a change in their mentation. But being able to have these conversations and helping you to say, it may be time to talk to the doctor. Or, these are the things you're looking for. So hopefully these kind of conversations will help in getting people feeling comfortable about doing that. Yes,
I was gonna say, I think that because most people always focus on the hospital, that maybe they need to be more, like you said, they need to work in conjunction with the hospital. Everybody will immediately go to 911 emergency room. And then, like you said, sometimes it's a little more than the hospital can deal with. But it looks like they need to at least be aware of when this patient may need something more than that they can have or handle. And I think if they work more in conjunction with the hospital, everybody knows about the hospital.
that's right. That's right.
And
So
then
it's
I
nice
think
to know.
And I think a lot of people also think that hospice involves, so much money. I can't afford it. So if they understood that it's not about money, it's not about this, well, it's about money, but you know what I mean?
Right,
Yeah.
it's not gonna cost them. They won't end
Exactly.
up bankrupt.
I think the people at the hospital are doing a little bit better job of.
Yeah.
It used to be, if you got to the emergency room, you were gonna get admitted. Nowadays, they're doing some evaluations, and if this patient is hospice appropriate, they've been here 4 titimes in the last month,
Yes.
whatever.
Yes.
So, but it's a slow process.
I think we have a Zoom question.
So it's more of a comment that I think all of us are saying the same thing. You mentioned getting paperwork in order and having communication with stakeholders. I'm doing that, but I'm scared I'll be a mess when I have to deal with this. Intellectually, I know it's coming, but.
So that's perfect, because next week, we're gonna have Paul Malley, Director of 5 Wishes, which is probably the best advanced directives I've seen, which helps you in leading those conversations that you should have with your family members and your caregivers, and those decisions that need to be made, all of that Dr. Zorn had mentioned. It's not only about choosing who's gonna make decisions, but what those decisions are. That is a gift to your family, because it doesn't lay on them to make the decision, then what they're doing is following your wishes. And there won't be a question with different caregivers or family members, because they're all gonna be following your orders. So that's the first part of next week, is advanced directives, and the second part will be a attorney who will be helping discuss more of those kind of what kind of legal documentation you should have in place, what things are helpful, so that you're leaving your family with a better situation. So please join us next week.
But I think she's right, because, you know, all of this is really good for us sitting here. Everybody's breathing pretty easily and not in too much pain, I hope. But you go from the intellectual to the emotional when you have that crushing chest pain or, you know, whatever. So understanding that there's gonna be, you know, go from the intellectual to the emotional, you need some, you know, how are you gonna handle, you know, that? And that's why I think the more people that are involved in it, more people on the same page, when you have that episode, then you don't have two people that are talking about, you know, giving you this and two people who are fighting over here about what you're gonna do. So, yeah, it's different when it comes crunch time.
Yeah, those are much easier conversations to have. I mean, you can even laugh about some of the questions and requests and thoughts that come up when everyone is good. So, but okay, any other questions? Any other Zoom questions? Yes.
This is just a comment. I heard Steve Martin say once that I knew about this death thing. I didn't know they were talking about me.
That is.
I said that to the kids because I thought it was funny and they freaked out. They thought they were talking about me.
Yeah, it's not an easy discussion.
But thank you all for coming. Oh, we have one more?
No, just a comment.
Okay.
3 weeks ago, a coworker of mine, a librarian, in fact, a family, died. And after listening to your presentation, if we had known about this, I think he would not be dead. This was his second cancer. His first cancer was esophageal cancer. He went and had surgery and he recovered. The cancer, then that was followed with prostate cancer. And all the while, he's still working at the main library at Fairview, a crucial librarian. He wore about 10 different hats: scholarly, publications librarian, interlibrary loan librarian, digital repository librarian, copyright librarian. And we were very close. We talked every day. He never, I don't think he knew. Because what happened was, the pain of the prostate cancer was so great. We talked about it, and so he went and had surgery for that. And that was at Gainesville at Shands. And when he came back here, he had to prep for a week before he went down on a Friday to have the procedure. And long and story short, he had the procedure and he came back here. And the next day he died. You know, armchair physicians are
That is
saying, you
very
know,
hard.
those of us who know nothing about it, are saying that his body just couldn't take any more surgery. He had had esophageal surgery, where they had moved a portion of his esophagus, and he was on, you know, a restricted diet for quite a while until he finally got, you know, and all the time he's still going to Coleman Library and still working. And oh my God, you know, Pam was his supervisor too, and they were as close as he and I were. If I had known about this, he might still be alive.
Well, it's, you know, not knowing the particulars of why, you know, why they felt they needed to operate or what, you know,
Well,
exact
that was his
procedure,
choice.
you know. And
That was his, he felt.
it was
You know,
necessary.
we have to live with the decisions we make, and those are very
Yeah,
difficult
exactly,
situations.
exactly.
And I-
That was his decision.
That
We
made,
talked about it.
exactly.
Because he said the pain got to the point where he just couldn't take any more pain. And I knew something was wrong the Saturday before he passed, because we were Facebook buddies, and he put up a Facebook post that said, I'm at my lowest hour. And all I could think of to do was I wrote it back, I said, just continue to pray. And I did not know he had passed until I called a coworker. And she paused in the conversation for a long time. I said, well, what's wrong with that? She says, I don't understand. Died, so you don't know. Because people knew how close we were.
So sorry, that is very difficult. And,
Well, doctors are not very good with the word no. I mean, if you go and ask a doctor for something, he's sort of taking that as permission to do something. So you have to be a little bit careful, because most doctors will tell you yes on procedures or new medications or chemotherapy or whatever. So, they may or may not give you another option.
Because of his background and his personality, he was very proactive in terms of advocating for himself. He would do the research when they would send him to the specialist, he and the specialist would have to have a meeting of minds, because he would tell them up front, I've done the research, I'm a research librarian, and it's similar to what I told my primary care physician. I said, let me tell you something, you went to medical school where you studied the human body. You didn't study this body. I know this body better than any other human being on the planet.
that's right.
Because I
It's
have.
important to advocate for
Yeah,
ourselves.
exactly. When I first came back to Tallahassee, I was taking medication for hypertension, and he had me on 100 milligrams of atenolol in addition to 2 other hypertensive medications. And I take my own blood pressure because I have my own machine. And I told him, I said, I want to tell you something. You have a choice. Either you stop prescribing this for me, or else I'm just going to stop taking it. So he said, what's wrong with you? I said, the other day my blood pressure was 75 over 50 something. I almost have low blood pressure. You're over medicating me. People have to learn to speak up.
Yes.
You have to act. And this guy was that kind of a guy too. No, I get my primary care physician. I get him straight, to make a long story short.
And that's part of this discussion, and wanting people to feel like they have these options and that they can have these conversations.
I am
with their
76 years old. In 4 years, I'll be 80.
You know?
And I don't plan on going anywhere anytime soon.
Good.
I believe in what's in Genesis 6:3, that we can live to be 120 years. I really believe that. And it tickled me when about 10 years ago, I saw all these articles in medical journals, the medical professor that's finally determined that the human body could last about 120 years, and I was just, I just fell out laughing. Anyway, that was just.
Well, thank you.
I
Thank you for
didn't just
sharing.
enjoy this.
Oh, good. Well, we have a video that was sent to us that's, again, about celebrating life, about quality of life, and about, doing the kind of things that matter to us. So it's a great video, and I'm gonna step away and turn my screen. Thank you all so much.
Thank you. Thank you.
Betty,
Yes,
will end with this?
yes.
Okay, you're more than welcome to leave that.
One nothing are the Blue Wahoos here at Blue Wahoo Stadium on this Friday night. And I am joined by 2 very special guests. We have Jeff Miss Levy and Angela Bottassini. You guys are here with Covenant Care. And the reason why y'all are here is earlier there was a flyover during the national anthem. And from what I hear, there was a 97-year-old World War II veteran, and he had one wish to give. It was part of the My Wish Foundation to fly one more time. He was a pilot in World War II, and he flew at 97 years old during the national anthem.
It's been 82 years since I've been in an open cockpit airplane. I always said the only flying that is to me and remembering is an open cockpit airplane. I was a pilot of a 4-engine bomber, B-17. I was shot out of formation over Berlin and almost lost my life, but the Tuskegee red-tailed pilot saved my life. Well, I appreciate your recognizing how wonderful it is to still be alive at 97. About 11 years old, when I was walking to school one day, a plane landed beside me and I'd never seen before. And from then on, I wanted to be a pilot.
Veterans flight ground, veterans flight ground. Do you receive the steerman?
Copy that, we're locked in and in position.
Okay, we're holding over the water tower right now.
Veteran Air, the national anthem is beginning now.
Roger that.
It's recognition of what happened 70 years ago almost. And I'm grateful that somebody does know of the sacrifices that were made back then to keep us a great country.
I think what's unique about the My Wish program is that we're able to take community members that have a passion about helping somebody who's at the end of their path and the end of their journey do something really memorable and meaningful to them. It's a difficult time, and you can imagine during that time period, but it's an opportunity for them to really focus on themselves, as they usually are worried about taking care of their families and planning for what's next.
And that's that. Thank you guys for coming.
Thank you all so much. Please don't forget to fill out the evaluation for us.